In the remaining units in this course, we're going to be talking about some of the more fascinating pieces of psychology, those being psychological disorders, where they come from, and how they're treated. In this lecture, we're going to be talking about what psychological disorders are and how they're diagnosed. So we'll start with the basics. Next slide. As we begin talking about disorders, here's a question for your consideration. What do you think? If a person with a mental disorder commits murder, should he or she be sent to a mental hospital or to prison? And should the death penalty be considered? This usually raises some lively discussion when people discuss this kind of topic, with people having very different opinions. Some folks saying, mental disorder or not, someone should go to prison if they've done the wrong thing, and even the death penalty is reasonable. Other people saying, no, a person with a mental disorder doesn't really understand what they did, and so therefore they should not be treated the same as someone who does understand what they've done when they committed the crime. These kinds of questions are helpful because they illustrate some essential points to think about when we're talking about psychological disorders. First of all, the type of psychological disorder makes a grave difference in terms of whether a person should be sent to a mental hospital or prison. Some psychological disorders leave a person completely in control of their faculties, completely ability to reason and take responsibility for their decisions. Other psychological disorders leave a person with what might be called poor reality testing. That is, they're not able to have good contact with reality. They're not able to think about realistically what they should or shouldn't do. So the type of mental disorder makes a difference. The severity of the mental disorder also makes a difference. For example, depression can range from very mild, which can cause the person hardly any impairment in their life, all the way up to the range of severe, where a person might actually lose some contact with reality and have poor reality testing due to depression. Another thing that must be considered is the ability of the person to take responsibility for their own actions. Were they able to take responsibility for their actions prior to the onset or the beginning of the mental illness, or before that were they still unable to take responsibility for their actions? All these things are important and lead up to just a whole lot of questions that are not very easy to answer. One of the ways that psychology and mental health have intersected is through the use of psychological principles on the streets in law enforcement. Take a look at the video Cop Psychiatrists before you go on. Next slide. As we begin talking about psychological disorders, I need to make a few disclaimers. To begin with, I am a licensed psychologist and have practiced for a number of years as a therapist. And one of the things that therapists have to do is to maintain confidentiality of what their clients say to them. So when I see a patient, I'm not allowed to tell what's going on with that patient to other people. I'm not allowed to reveal what's called identifying information, so that someone might be able to tell who my clients are. However, when it comes to education, such as this intro psych course, it is permissible for general information about cases to be used for educational purposes. And so throughout the time I talk about psychological disorders, I'll probably mix in a few examples of some things that I've seen in my own practice. And the thing to remember is that I'm not going to mention names of anybody. I'm not going to mention enough details of anybody about any patients for them to be identifiable. Another thing is that all of my clinical practice was done in a different state, so it's very unlikely that I would break the confidentiality of anybody, given that it's not likely to be someone that you'd ever come in contact with. So I will tell some about psychological disorders for education's sake, but I will also maintain the confidentiality out of respect for my clients. The second disclaimer is that of med school syndrome. People who go to medical school sometimes find that as they learn about various diseases, they see symptoms of those diseases in themselves and they become anxious, feeling like maybe, oh, I've got this disease or I've got that disease. The same can be true when you learn about psychological disorders. As we talk about symptoms of psychological disorders, you may find that there are some things in these psychological disorder symptoms that match your own experiences. That doesn't necessarily mean that you have that disorder. It simply means that there are some things that you might have in common in the human experience that are like people who experience that disorder. However, if you feel like one of the disorders really fits you, feel free to email me, or better yet, feel free to talk with someone at the McMurray University Counseling Center. The third thing is, disclaimer, is that psychological disorders are really, it's not really a matter of talking about them, talking about other people. It's really a matter of talking about us. I know I say this to my students in a classroom setting, that when we talk about psychological disorders, we're talking about us, that there are people in the room who experience psychological disorders. And so what we have to do is to handle them in a handle the disorders in a respectful and caring fashion. As you can see from the statistics here, 43% of people in America will experience some psychological disorder within their lifetime. So that's almost half of us will experience a psychological disorder sometime in our lifetime. Almost 30%, or about 30% of us will experience a psychological disorder within a given year, a given 1-year time frame. So psychological disorders are quite common, and it's not a matter of those people out there who have them. It's a matter of all of us who experience this kind of common thing. Next slide. Okay, take a look at these 3 pictures at the bottom. Which of these people has a psychological disorder? The woman on the left, the man in the middle, or the man on the right? The truth is, it could be any one of them that has a psychological disorder. Perhaps all of them do, or perhaps none of them do. How would we know what a psychological disorder is and whether a person has one? How would we know at what point abnormal behaviors become actually a disorder? As we look at each one of these people, we could probably pick out some characteristics in them that seem somewhat abnormal or unusual. But at what point does that actually become a disorder? 3 things need to be kept in mind when we're trying to figure out the difference between something that's unusual and something that's disordered. So let's take this example. Let's say that as a therapist, I have a client come in to me and says to me, he says to me, my classmates are all jealous of me because all my female classmates find me attractive. Well, is that abnormal? Well, it's kind of unusual to hear someone say, well, my classmates are jealous because all my female classmates find me attractive. That's kind of abnormal sort of statement. But is it really a disorder? First of all, to know whether or not it's a disorder, we have to consider whether the behavior or the experience is consistently deviant. That means consistently deviant over time. So if I ask my client who has just told me that, if I ask, okay, how long has this been occurring that all of your male classmates are jealous and all your female classmates are in love with you? And he says, oh, the idea just occurred to me one day. I said, well, is it any more than that? He says, no, just occurred to me one time. Well, that's not what we'd call consistently deviant. However, if I ask that question and he responds, well, I think about it all the time. I think about it in class. I think about it out of class. It's been going on for months and months. Well, now I have some evidence that that sort of abnormal experience is consistently deviant. The second criterion is whether or not the behavior or emotion or thought causes distress to the person or distress to other people. So the guy says to me, all my girl classmates are in love with me, all the boy classmates are jealous of me. And I said, does it bother you? And he's, nah, I don't care what any of them think. Well, it's not causing him distress. He's not worried about it. Maybe he just came in because someone recommended that he tell a counselor, but he's really not distressed by it. Probably not a disorder if he's not distressed by it. However, if I ask him, does this bother you? Are you distressed by these thoughts? And he says, well, I worry because the guys are looking at me and talking about me, and I think they may be plotting against me. They might want to kill me. And so I'm really afraid. Now we've got evidence of this being distressing. So it's consistently deviant. It's distressing to him. What about this third criterion? The whole idea of impairment of functioning. Functioning has to do with how well you're doing in your school, how well you're doing at work, how well you're doing in relationships. Are you functioning well? Are you keeping up with what you need to keep up with? Are you attending class? Are you making it to work regularly? Are you doing okay in your relationships with other people? So what about if I asked the young man that I was talking about, asked him about whether or not he's got any problems with school or work because of all of the girls being in love with him and all the guys being jealous of him. And he says, "Oh, I just ignore them and do my best in my course, and there's no problem." Well, obviously his functioning is not impaired if he just ignores it. However, if he were to respond, "Well, I've been missing a lot of class because I'm too scared to go out. I can't make friends with anybody. I can't even talk to my professor." Well, in this case, probably what you've got is some pretty significant impairment of functioning in his relationships, in his work, in his school. So, where does an abnormal behavior become a disorder? When it's consistently deviant, when it causes distress to the person or others around them, and when it impairs their functioning. Next slide. What are some of the things that cause a person to develop a psychological disorder? Where do these things come from? Surely you've heard of things like people being depressed or people having fears or phobias. Surely you've heard of things like people hearing voices or seeing things. People having moods that are extremely irritable. Where do psychological disorders come from? There's a couple of models that we list here that we're going to talk about. First model is called the biopsychosocial model. And there's really three things that go into the biopsychosocial model. The biopsychosocial model says that there are biological or genetic factors, psychological factors, and social factors. And all three of these things must be taken into account when we're talking about a psychological disorder and how it might develop. So let's take a quick look at each of these. What are some biological or genetic factors? Well, there are some disorders that seem to run in families. For example, schizophrenia and bipolar disorder are disorders that seem to have a genetic factor. That is, if the parents have them, the children are more likely to have them. We might say that this is, again, the idea of a nature explanation. Some of the things, for example, that are biological in disorders are schizophrenia. There seems to be an abnormal level of the neurotransmitter serotonin, one of the chemicals in the brain. In the disease Alzheimer's, there seems to be a biological component in which there's a decay of the brain itself. So some of these biological and genetic factors can predict if a person will develop a psychological disorder. What about psychological factors? Here's some examples of psychological factors. Past life experiences. One of the things that's been found is that children who are severely abused end up overall with changes in their brain. They end up with brains that are different than people who have not been abused. So, for example, the corpus callosum, that is the part that connects the two halves of the brain, is smaller in people who have been through severe child abuse. Overall, their cerebral cortex is smaller than people who have not been through child abuse. Some other psychological factors besides past life experiences are present stressors. We've talked some about stress already, and one of the things that happens with stress is there's an increase in the level of stress hormones in the body, such as cortisol or adrenaline. And this sort of psychological factor can bring on a psychological disorder. Also, another psychological factor would be a problematic learning history. For example, think about a child who lives in a situation where the parents do everything for her. They don't allow her to take any risks or do anything on her own. What kind of message might that send to the child? Maybe the idea of, don't be competent. You can't do anything for yourself. That would be a problematic learning history. As a child reaches adulthood, she may still carry with her that message, don't be competent, don't do anything for yourself. So psychological factors can end up with causing things like low self-esteem or feeling poorly about the self. Okay, let's look at social factors. Social factors may include expectations or pressures from the family or friends or culture. For example, In some cultures, there's a high premium on achievement and a high premium on perfectionism. That sort of pressure from the family or friends or culture may put stress upon the child. Another social factor that can influence the development of psychological disorders is prejudice. Prejudice based on things like gender or race or age. These are all things that may end up as social factors influencing the development of psychological disorder. We know that people who experience extreme poverty are more likely to experience psychological disorders. Okay, the biopsychosocial model says that you need to look at all three of these to understand where a disorder comes from. Any good therapist is going to ask questions that get at all three of these areas: the biological, the psychological, and the social factors. Is that the only model? Well, obviously not. There's a second model to take a look at, and that's the diathesis stress model. It too predicts if a person will develop a psychological disorder and what will happen, what will cause them to develop that. The diathesis stress model says we have to look at both a predisposition in the person as well as what stressors the person is under. Now, this may sound like a rehash of the biopsychosocial model, and it is fairly closely parallel to the biopsychosocial model. With the diathesis stress model, I want you to picture in your mind a brief picture here. Think about a piece of paper that you take and put perforations in it. So let's say you take a knife and you just make little cuts right down the middle of the paper. Then you have someone hold that paper on each edge and you press down in the middle of the paper. Is it likely to break? It is, because you've put some cuts in it, and so you've perforated, and it's more likely to break when you press down on it. Now think about another piece of paper that you've not done that to. Have someone hold each edge of that paper and press down in the middle of it. Would it break as easily as the paper that you perforated? No, it wouldn't. Why? Because it doesn't have that perforation already. The diathesis stress model says that people who are more likely to develop psychological disorders are those who have a predisposition, or kind of like a perforation. So the diathesis is a predisposition to develop a psychological disorder. Diathesis means that at some point, if you have enough stress, then you will develop the disorder. But if you don't have the stress, you probably won't. So diathesis is the predisposition. Stress we've talked about already, and stress is just the trigger for the beginning of the psychological disorder. So if we think about some of the famous cases, for example, the woman who drowned her children, she may have had a predisposition to mental illness. However, stress triggered that mental illness to develop and her to do these bizarre things. So that's the diathesis stress model. Let's go on and talk a little more about psychological disorders and diagnosis. Next slide. A diagnosis is a label that says this person has such and such psychological disorder. And it's useful, but it also has some drawbacks. So as we talk about diagnosing psychological disorders, let's talk a little bit about some of the underlying things that a clinician would be looking for if they need to diagnose a psychological disorder in one of their patients. First of all, a clinician is going to be listening for specific symptoms of the disorder. Symptoms are the things that the patient themselves report. So for example, if you go to your physician and you say, "I'm having headaches," can the physician see the headaches? Of course not. But can you report them? Yes, you can. Headache would be a symptom because it's something that's reported by you, the patient. So symptoms that might be reported to a mental health clinician would be something like, "I'm feeling depressed," or "I'm hearing voices." These are things that the clinician can't see or hear, but the patient can. In contrast with that, clinicians are also going to be looking for specific signs. Signs are things that are observable, that are noticeable. So let's say you go to your physician and you say, I have headaches, that's your symptom, and the doctor takes your temperature and finds that you have a fever. That would be a specific sign. A sign is something observable to the doctor. So in a mental health patient, some examples of signs might be wearing inappropriate clothing, like you saw on the cop psychiatrist video, or talking to oneself, or your speech not making any sense. Those would be specific signs. So in diagnosis, we're looking always for specific symptoms and also specific signs. Who are some of these clinicians that I've been talking about? Who diagnoses psychological disorders? To begin with, physicians like your general doctors or general practitioners, and also psychiatrists diagnose psychological disorders. Psychiatrists are nothing more than medical doctors who have received some extra training in psychological issues. They're the ones that prescribe psychological medications. Who else diagnoses psychological disorders? Counseling and clinical psychologists do. A psychologist is someone like myself who has a PhD, that is a Doctor of Philosophy degree, or a PsyD, a Doctorate of Psychology degree. Both of these are doctoral level degrees, and counseling and clinical psychologists work with mental health patients a lot. Who else diagnoses? Social workers do, counselors do. There are also people who are called marriage and family therapists who may also diagnose psychological disorders. So these are just a sampling of some of the kinds of mental health workers who are going to give diagnoses. Next slide. Finally, we take a look at the pros and cons of diagnosing. Why give a diagnosis? Is there any good of labeling? Well, I think we probably need to have some kind of justification for assigning someone a medical label, like a diagnosis. So let's talk real briefly about the purposes of diagnosis. To begin with, diagnosis helps us to categorize people. That is, it helps us to distinguish one problem from another. So for example, we may have two clients come in the same day, both of them complaining of difficulty sleeping. But if we look further and investigate further into what their diagnosis might be, we find that one of those clients is not sleeping well because he or she has depression. The other client is not sleeping well because he or she has post-traumatic stress disorder, which is an anxiety disorder that comes after some unusual or intense stress in the person's life. Very different reasons for the sleeplessness, and diagnosis helps us to categorize and keep it straight who has what kind of difficulties. Communication is the second purpose of diagnosis. So for example, with a simple diagnosis of attention deficit disorder, I can communicate to someone about the history of the person's symptoms, what their present symptoms are likely to be, what the prognosis is for change, what the treatment options are, etc. So communication is something that's an especially important part of diagnosis. One small label can help a mental health clinician to know a ton about the patient. Finally, compensation is a purpose of diagnosis. By this I mean monetary compensation. Medical insurance companies are not likely to pay without there being some sort of diagnosis. In other words, they want to know specifically whether or not the person actually has a disorder and what disorder it is before they're going to give any money to pay for treatment. And this is important. Important partly because mental health professionals have to make a living, and so it helps them to get monetary compensation for the work that they do, but important also for the patient, because the patient, if they have insurance, should have the right for the insurance to pay for treatment, to help them out. And so compensation is an important piece of diagnosis. Are there drawbacks of labeling someone, of diagnosing someone? Well, one of them, of course, is labeling. In 1973, a psychologist by the name of Rosenhan had a number of people who worked for him go to psychiatric hospitals and complain of hearing voices. They were not hearing intense things. They just went and said things like, "I'm hearing a word in my head. I'm hearing a voice say the word thud," for example. Based on this, all of Rosenhan's research workers, none of whom were mentally ill, all of them were admitted to mental hospitals based on hearing voices, just that symptom of hearing voices. The hospitalization for his workers ranged anywhere from 3 days to 52 days in length, and many of them were diagnosed with schizophrenia, a severe mental illness. Well, what's the effect of this sort of diagnosis, or this sort of label? Well, can you imagine being someone who worked for Rosenhan? You went to a mental hospital and you said, "I'm hearing a voice in my head that says thud," and they admit you and they want to put you on medication, and when you try to explain to them, "No, I'm really not mentally ill. I work for a psychologist by the name of Rosenhan, and I just came here because of him," can you imagine what how the doctors are going to respond? They're going to see that label, that diagnosis of schizophrenia, and say, "Right, sure, you're just making all this up. This is all a bizarre belief on your part." So a diagnosis has a lot of power because of its label. A diagnosis also can have the drawback of affecting a patient's self-concept. Sometimes a person might come to see themselves as a depressive rather than the person who's dealing with depression, or a schizophrenic rather than somebody who's dealing with schizophrenia. It's not uncommon for mental health professionals to slip and say things like, "Oh, I saw 3 bipolars today," rather than say, "I saw 3 people today who are suffering with bipolar disorder." So it's possible it can affect the patient's self-concept by affecting the language we use about the patient. Finally, a final drawback of diagnosis is sometimes it can distract from treatment. How this can happen is occasionally you'll have a patient who will come in who wants to spend all of their time discussing their diagnosis and arguing about their diagnosis rather than actually taking steps to heal and get better. So sometimes people will get so wrapped up in diagnosis and whether or not it's correct that they're actually not worried about trying to get better, and they use it as a way to avoid doing what they need to do. Okay, so this lecture, to recap, has been a quick picture of what psychological disorders are, where they come from, and also how they're diagnosed. End of lecture.